Do some of that. And we're Yeah, don't worry about it. Don't worry. What is up, everyone? That came on fast. I'm here with my good buddy Adam Green. What is up, my man?
Not much. How you doing, Haney? What are we?
I'm doing.
What
Huh?
are we? Is it fall? What's the season? Where are we at right now?
It's fall. It's fall. I mean, fall is it's always a relative term. The leaves are changing color, and it's still 95 degrees. So I don't know what to call it. Maybe it's fummer or sol. What do you think? I think as the climate changes, we're gonna have to come up with better seasons.
Yeah. I'm gonna start counting how many times you ask me questions, and I'm just totally confused. This will be the first one this episode.
Okay, this is kicking it off. Well, it's good to see you and good to see everyone. We are back with the Critical Care Lounge. This week we have two very, very, very special guests with us, but we will tell you about them in a second. We are going to be talking about trauma this week, but specifically blood transfusions. And with that, let's roll the tape, and then we can talk about what we're going to do today. There was supposed to be a lot more explosive music over that, but like 5 minutes before this launch, the music just died. So I was going to hum something. Was it?
That was life changing. Thank you so much. For sharing that.
All right. Well, thanks a lot, man.
All right. Who do we got? Let's get
today on this episode of the Critical Care Lounge, we have two very special guests, and I'm not being facetious when I say that. We have two very, very smart trauma surgeons, but besides being trauma surgeons, they're also intensivists, because I believe that there are people who do trauma, and then there are people who do trauma but understand what happens when they get out of the operating room, and these two individuals get just that. And so let me bring them on and we'll introduce them. Please welcome to the broadcast Dr. Salina Wydo and Dr. Dennis Kim. Salina Wydo is a physician here at Cooper Medical School, and also a phenomenal trauma surgeon who we both get to work with daily. And Dennis Kim, he's in Vancouver, correct?
Yeah, Vancouver Island.
Vancouver Island, yeah. And you know, just a phenomenon. I actually met him, and none of you judge me out there for this. I met him on TikTok, but he's a lot more than a TikToker. He's an educator with a podcast, and his scope of practice just goes beyond social media. So it's great to have both of you on tonight. Thank you for being here.
Thanks for having us.
For sure. All right, you want to kick it off with the first question?
Yeah, you know, I'm gonna throw a curveball, Haney, and I didn't tell you I was gonna do this, but
ease them into it. A curveball.
Last episode, you started asking things like favorite cheesesteak, and I was totally unprepared. So I thought we would just ask a non-medical question to start.
Okay.
Just to kind of get a warm up and then jump in. Okay. So
I like it.
Haney, so I was thinking, I would love to know your guys' favorite condiment and why. What do we got?
One. It all depends, I think, on the cuisine.
Yeah, give him like a.
You only get one. You just got to pick one. Like I'll say,
well, hamburger. You have a hamburger.
That one.
Barbecue. What are we doing?
Yeah, but what if it's sushi or sashimi or?
Right.
Well,
okay, let's go with sushi.
I think I want the ketchup.
Yes. Ketchup.
All right. How about you, Salina?
Really
what do you say?
Probably
I think you really threw a curveball for sure.
Yeah, I didn't anticipate.
You really did. I did not see this coming. Being from the Midwest, I think I'm going to have to go with mayonnaise, because you can put it on any vegetable and call it a salad.
How about mayonnaise with French fries? Like that whole, what's that whole thing they do in Europe?
Yes, like mayonnaise mixed with mustard, like fry sauce.
Yeah.
Or like dill mayo.
Mm-hmm. All right.
Okay. All right.
There
you go. Very good. Are you happy now?
No, not really.
You've thrown the whole show off with your condiment question.
Yeah, I know. I was like ready to say mustard because it's versatile. You know, you can go honey mustard, but whatever. All right, that was a bad idea. I'll never do it again. Let's move forward. Dennis, I loved our show. You are the first ever 2-timer on the lounge, which is exciting. And I think we talked a lot about whole blood, so I think there's going to be some overlap here. And some of these questions are repeat from the last episode, but I think it's worthwhile. So I love this concept of trauma pack, and we have massive hemorrhage, and someone says, "Get us a trauma pack." So first off, I'm interested: is that a uniform term across all institutions? Is this, if you say trauma pack, does kind of everyone know what that means? And I'm really interested, kind of just your general approach to massive transfusion, and what's going through your mind when you're thinking about ordering blood products.
Yeah, so as someone who's recently moved institutions after spending about 10 years in LA County, I can definitely tell you, even amongst hospitals within that large regional system, the term trauma pack or even MTP, MHP, it varies. And coming up to Canada, I've seen the same thing, and we have a serious deficiency and lack of specific types of products, specifically platelets, which I think is a major problem in most places these days in North America. So I think trauma pack, really the emphasis there is we're thinking about damage control or hemostatic resuscitation. And so long gone are the days of pumping our bleeding trauma patients full of pasta water, normal saline, trying to chase these silly targets like a systolic of 110. We don't do that anymore. We know that we need to get hemorrhage control, so rapid evacuation, transport, pre-hospital triage to the local trauma center, identify and stop the bleeding, and then initiate the trauma pack. So that's going to vary. It's going to vary depending on your local resources, the blood bank, and what you have available. And in some cases, you may be fortunate to have whole blood. Otherwise, it's going to be some sort of reconstituted component therapy. So RBCs to FFP to platelets, typically apheresis, in some predetermined ratio.
Salina, how about you? What's your thought when someone yells trauma pack in the Bay?
We're lucky enough to have a couple different upfront options, one of which includes whole blood. We actually have a pretty good amount available to us right away. So one of the things I think that we have that we're a little bit lucky about is we have our own blood fridge in the trauma bay. So before we even call for the packs, we can start transfusing what we already have immediately available to us, which does include whole blood, which has a couple of uncrossed units, has some FFP. When we call for a trauma pack, in my mind, what I'm used to for the past 10 years working at Cooper is getting the first 4 units of uncrossed reds and first 4 of FFP. But honestly, we have something called a Porter pack named after our division head, John Porter, who worked with the blood bank to have it. And you call for a Porter pack and you're getting 3 units of whole blood. And then you can continue that going when you get up to the operating room. You can continue with your whole blood resuscitation, which is really nice. Initially, when we started that program, there were some limitations to what we were giving, on whom and how many units. And now we're really able to be pretty liberal with it, which has been a very nice change.
Let me ask a question just because it benefits me locally, and I wasn't really sure as to why, but why locally here do we not include platelets as the trauma pack?
It has to do with the likelihood of us actually continuing resuscitation beyond the trauma pack. A lot of our patients will get just that first cooler. Typically when we say trauma pack, it's the first pack of our massive transfusion protocol, just minus the platelets. And a lot of our patients, we're able to get hemostasis before we have to really go down that cascade. So if we can correct the bleeding, obtain source control, and then replete with what's in that trauma pack, then the platelets are unnecessary. And as Dennis had mentioned earlier, I think not just nationwide, but I think probably at least continent-wide, one of the big limitations of our component replacement therapy is going to be the availability of platelets.
Gotcha. And you mentioned the Porter pack. Speaking of Dr. Porter, do you know what his favorite condiment is? No, sorry. That was okay. So let me ask you all. I assume that you are not mayonnaise.
Yeah.
He's a fascinating guy. I actually do want to know what his favorite condiment is. But when you are transfusing in a 1-to-1-to-1 ratio, that's the kind of mantra that we think about, but are there ever situations where you have patients coming in who you will deviate from that? And I'll give you a specific case because it's unfair of me to say in all cases of hemorrhagic shock that you see. Let's say you have a person who comes in, penetrating trauma, they're in the bay, and you order, a trauma pack. Is there ever a situation where you're not giving 1-to-1-to-1, or is it well established now if someone's bleeding out pure blood, they should get a replacement of whole blood or full components of that?
Salina, you want to take that one? Or
Yeah. I would say honestly, in like the penetrating trauma patient, most of whom are young, most of whom have relatively few medical comorbidities. No, I'm probably going to just kind of, I was going to say shoot for, but that's a really horrible choice of words. I would aim, that's not any better. I would still try and achieve a one to, I'm trying really. I would try and achieve still a 1-to-1-to-1. The people in whom I would deviate from that would be if you got some of my blunt trauma, some of my people who are in the older age cohort, who were on systemic anticoagulation, whether that be warfarin or DOACs. And I would probably lean heavier towards FFP, heavier towards platelets, heavier towards earlier giving of cryo in kind of that population. But in the person you gave me, the penetrating trauma, no, I'm really going to try and just go for 1-to-1-to-1.
Yeah, I agree. I think in patients who are bleeding, they're at a high risk for exsanguination and death. You want to be on top of it, 1-to-1-to-1. For the penetrating trauma patient, we always emphasize this. If they've got a palpable pulse, they're rousable, don't give them anything. Get them up to the operating room, do your surgery, get control of the bleeding vessel, and then start with your resuscitation. I think Salina brought up such an important point that we take for granted these days. That blood refrigerator has to be in the ER at the point of care, not on the second or third floor in the blood bank waiting for someone to run that blood product down. It's got to be there in the trauma bay. When it comes to the 1-to-1-to-1 and the trauma pack, I think one of the other things to emphasize is that you want to be thinking about giving calcium up front and early, not waiting for your 10th unit of RBCs, because these patients are going to be hypocalcemic, and hypocalcemia is part of that sort of bloody vicious diamond, if you will. And then think about your TXA, which I still see people forgetting. Where I'm practicing now, our pre-hospital folks are so good about giving it in the pre-hospital setting, 2 grams IV, bolus, no drips.
Great,
so
thanks guys.
I have so many questions from all this. So I love that we're focusing on the trauma patient because you guys are trauma surgeons. I also, and we don't need to comment on it now, but I also, for some of these questions, a lot of the audience are going to be medical intensivists. So like talking about whole blood is wonderful, but I am relatively positive that I can't get whole blood for my bleeding cirrhotic that's upstairs in the medical ICU. So, I think that's something to keep in mind. Just even like you mentioned, TXA, is there a role for IV TXA in the non-surgical or trauma patient? I know we do it sometimes, but I'm not sure that's a proven practice. So my question,
I think you got to be careful because we definitely know in certain patient populations, upper GI bleeds, it's probably harmful. And again, one of the big things with TXA is giving it early or within 3 hours from the onset of bleeding. And most GI bleeds are occult. We don't know exactly when that varix bursts or when the angiodysplasia starts to let loose. And so I think for now, outside of cardiac surgery, acute trauma, a lot of the sort of level 1 data is pretty limited when it comes to TXA. But just to get back to that question Haney had about, do you always give 1-to-1-to-1? Well, I think these days, as we've already said, you start with whole blood. And depending on the protocol at your local institution, that may be 2-4 units or more, depending on what you stock. And we're going to be doing TEGs, right? Together, that damage control resuscitation concept also includes real-time in vivo testing of coagulation. So if we've given a couple units of whole blood, we're doing 1-to-1-to-1. Well, every half hour, you should be getting a TEG and seeing what you need to actually be giving what factors are deficient, and then maybe you can back off and really tailor your resuscitation. And we know that this is going to result in improved blood utilization, less wastage, probably not going to improve mortality. At least the data is not quite there yet.
Let me just ask a question to be complete about this, and I'll ask Salina this first. You have we should be sensitive to the fact that most places don't have whole blood. Is that fair to say at this point in time? Like most, if we're being honest here, we're lucky that we get to work in big centers. But what would you tell the center that is smaller, that still has trauma rolling through their doors, in terms of what they should be doing in terms of transfusion and, in regards to TEG? Because let's face it, they probably don't have TEG in 2022.
No, that's totally fair. One of the big things that because it is not unusual for us to get folks transferred to us from smaller level 2, level 3 hospitals, or folks that don't have trauma even at all, but will still get things rolling up to their door. We'll see patients who are in need of resuscitation, but they just don't have the blood bank reserves and resources to give. One of the things that I would say is for folks in those hospitals, don't stress about not having the product to give. As important as it is to replace blood that's being lost, source control is more important. So trying to get them to a place where we can obtain rapid source control and then really hammer the resuscitation is important. We talk about this hypotensive resuscitation. We talk about trying to be judicious or conservative in the beginning because we don't want to artificially raise their pressure. We don't want to over-resuscitate, run into pulmonary complications as we're trying to save them from their exsanguinating hemorrhage. We don't want to raise their MAP to the point where now we're blowing off the clot, so to speak. So I would say give what you can, resuscitate how you can, but rapid source control is still gonna be the mainstay of what's going to save this patient.
And this description or this scenario, that's exactly where I am now. I'm coming from a level 1 trauma center in South Los Angeles where we have all the bells and whistles. We've got an OR on standby 24/7. And now I'm in more of a community setting. We don't have TAG. We don't have whole blood. We don't even have a blood refrigerator in the ER. So I have to kind of reemphasize exactly what Salina said. You need rapid control of blood loss. If you've got a blunt polytrauma patient, you're concerned that they're hypotensive and bleeding, put a pelvic binder on. If they're bleeding from an extremity, put on a tourniquet, pack, put pressure, and you got to scoop and run and get these patients to the operating room.
I'm going to let Adam ask the next question, but it's sort of a follow-up question. This might sound a little strange. We are in critical care moving from using less fluids overall to using an early vasopressor strategy for patients. Now, I am not suggesting an early vasopressor strategy for trauma patients, but my question is, looking into the future, do you think there will come a point where we look back and say, man, we gave a lot of blood when patients rolled through the door, maybe too much blood?
Yeah, I think vasopressors in the trauma bay is really, it's wide open for research and discussion. And it's been one of these dogmas, never give a hemorrhagic shock patient vasopressors. And then we have Dr. Carrie Sims publishing a paper looking at early use of arginine vasopressin. And although there was no major difference in terms of end organ dysfunction, mortality, they did have about a unit or two of less allogeneic RBC transfusion. And so is it potentially safe? I would say, yeah. I tell you, on this island, it's vast. And we have patients coming from remote areas where they're literally being transported, across rivers on rowboats. And there's no blood and there's no fluid. And these patients come in on vasopressors. So what's the right dose? What's the right target? What are our endpoints? That all remains to be defined. But I would never exclude use of vasopressors, especially if you don't have blood and blood products. You're waiting to get up to the operating room and the patient's literally dying in front of your eyes. I think in those situations, you have no choice. And you got to wonder, is it better to fill them up with a bunch of NS or LR or start them on some low-dose vasopressors just to maintain some sort of a MAP? So it's a great question. I don't know that anyone knows the answer, but it is ripe for research.
What do you think, Salina? Any thoughts on that?
I'm a really big fan of vasopressin and refractory hemorrhagic shock, and it was actually based mostly off of some of the work Carrie Sims had done, but I don't know. Honestly, it's such a complicated question. There is so much nuance to it. It's probably going to depend on each individual patient. We know that excessive volumes of crystalloid is harmful. We know that excessive transfusion wastes a limited resource and has some immunologic consequences. So, over-resuscitation in that regard is not optimal either. But then again, neither is putting somebody on a million mics per kilo per minute of levo, and then all of a sudden their entire bowel's necrotic. Um, so there may also be a very specific patient in whom the pressors are more beneficial than others. You've got folks who have more brittle physiology, more vascular disease. They may not tolerate the end organ ischemia, this splanchnic vasoconstriction. But honestly, this is so the argument becomes almost so esoteric because we don't have information on it that I almost hesitate to. I mean, I can opine, but I don't know that I don't know that I'd be any more right than anybody else.
Cool. Well, thanks for that. I appreciate you trying to peer into the future. All right, I've hogged up enough questions, and I have a million more, but I'm going to let Adam ask the next one.
Yeah.
Next one.
I was gonna say, Haney, you want to do that thing again where you say Adam's gonna ask the next question, but then you just ask one anyway. So
fair enough. I'm muting myself.
Yeah, there you go. Goodbye. So my question, I have another question. So I think the acute bleeder I get, right, 1:1:1. How about the oozer, right? We've all had those patients that are requiring 3 or 4 units, maybe every 24 hours. And, I think I've seen 2:1:1, 4:1:1. Like, what's the point where you start really worrying about dilutional thrombocytopenia, dilutional coagulopathy from just replacing the pack cells? And I know this is not the acute bleeder. Like, what's your approach to that? How do you guys think about that?
I think the nice thing with, and I don't want to say the nice thing with those folks because obviously you don't want anyone bleeding, but the nice thing about those scenarios is you typically have time to have lab data turnaround, and you get to spend more thoughtful time at the bedside instead of having to make right now decisions for that person who is in hemorrhagic shock. This is something where you could follow your fibrinogen levels. This is something where you can do your platelet assays, where you can get more information and then tailor it specifically to that patient instead of necessarily having just like a broad, like numerical target.
So that's interesting. So in fact, there is no 4:1:1. There is just replace the product and don't worry about it. Yeah. I mean, I guess that's, I always wonder, your platelets start at 300 and they're in a little DIC. I don't know. You give a bunch of blood, and even though the platelets are now 100, is that a threshold that you should give it? I guess I struggle with that a little bit.
Yeah, it's hard. I think using just absolute numerical values probably isn't the right way to go. I think that's one data point. And then you got to look at what else is happening with the patient. Are they making urine? Is their mentation better? What's their lactate and base deficit? Is it going in the right direction or the wrong direction, or kind of holding steady? But I agree. I think in these cases, I usually don't get too excited. And, it sounds like you have time. It's not that true life-threatening bleeding that gets trauma surgeons excited. So I'll usually just ask the resident what they want to do and then go with that.
What does get a trauma surgeon excited? That's the question.
Yeah. And just because you have platelets doesn't mean they work. DDAVP is always an option too if you think that there's a component of renal dysfunction that may be impairing, or antiplatelets on board, etc.
Right on. The other thing we didn't mention is that we're seeing more and more use of 4-factor prothrombin complex concentrate. And people are now starting to look at the use of whole blood with or without 4-factor complex concentrates, and whether or not that results in a decrease in the incidence of mortality, end organ complications like ARDS, as well as volume or units transfused. And at least based on some of the retrospective data using the TQIP database, we're starting to see that there may be an adjunctive role for things like PCC.
So yeah, and along those lines, I'm glad you brought that up because when we talk about transfusing, maybe not so much whole blood, but when we're doing one-to-one transfusion, one of the things that's come up more recently is the lack of calcium replacement. And I'd like to go into that a little bit further if you don't mind. And I think more and more people are realizing that you should give some calcium as you're giving your blood products, as there's chelating agents in the blood. But one thing that I haven't gotten a solid answer on is, one, how much calcium do you give? And two, at what point in your resuscitation or your transfusion of products do you give the calcium? 2 red cells, give some calcium. 4 red cells, give some calcium. Whole pack is done, give some calcium. And I know there's no great evidence-based answer that I'm aware of, but could you enlighten us on how you approach that? So how much calcium and when do you give it?
You want to go for it, Salina?
Sure. Um, so the real life answer is when I remember to ask my colleagues how many units have already gone in. Usually that tells me enough time has passed that we're at a number that I should give calcium. What that equates to is usually about every 4 to 6 units. And then how much you give is going to depend on whether you've got calcium chloride or calcium gluconate. If it's calcium chloride, I'll give like 1 to 2 grams. If it's calcium gluconate, give a little bit more. Um, People tend to tolerate hypercalcemia a little bit better probably than hypocalcemia in this standpoint, because you don't want them to get the coagulopathy of the chelation, the coagulopathy of the hypocalcemia. So you can probably err on the side of being even a little more aggressive than I am.
Gotcha. How about you, Dennis?
Yeah, I think typically by the 4th unit, and depending on the patient's physiology, I might even give it sooner. So even after the 2nd unit, some folks are talking about giving it then. It's amazing. These days, I am almost looking at calcium like a vasopressor. I'll have patients, non-bleeding patients in the ICU who are on multiple vasopressors and refractory shock, and their calcium's maybe a bit on the low side. You push an amp of calcium chloride or gluconate, and again, this is just empiric experience. You see their pressures pick up. And it's not just patients on calcium channel blockers, it's just sick, critically ill patients with multiple organ dysfunction. So, again, I think there's a role for early calcium replacement. And definitely by the 4th unit, I would be considering some supplementation.
That's good to hear, because that 4 was the number that I usually transfuse after. So to hear you smart people say it makes me feel a whole lot better.
Now, this may be silly. Is this 4 total products or 4 PRBC? So,
So that's a great question. Typically, I
Yeah.
think RBCs, bathed in citrate. But the other thing we didn't really mention is 1 to 1 to 1, but what's the right order? So we know that FFP
That was my next question.
is a great, oh, perfect. Yeah, it's a great volume replacer. It's got tons of proteins. We know that it helps with the endotheliopathy associated with the acute coagulopathy of trauma, and that it may help to stabilize that glycocalyx basement membrane, preventing further extravasation and vascular leak. So I think if you have thawed plasma ready to go, that's absolutely the right product to start with. DO2, yeah, we want to augment it, but honestly, early, that's usually not what I'm too worried about. So if you've got plasma, give the plasma.
Salina, same
Yeah,
sort of
before
thoughts,
we
or
had
what do you do?
Yeah, exactly. Before we had gotten whole blood and before we became so aggressive in using it, we were starting to shift to giving FFP as our first product. For all of the aforementioned reasons, plus it just makes me feel better that I'm trying to get that jump start on preventing the coagulopathy, even more so than repleting the red cells, since the delivery of oxygen data is kind of
Awesome. Adam, what's your next question?
Yeah, that was great. what's been next? What is the threshold to say give unmatched blood? What is your decision point of saying support the patient, resuscitate them with crystalloid, use some vasopressors, you know? And remember, most of these people here are medical intensivists, right? So when are you deciding that versus this is life threatening? We just have to give it. I can give examples, right? I've seen patients who come in with some, I don't know, complaints of melita and have a hemoglobin of 3, and I've seen ERs give unmatched blood for that patient. I've seen the opposite where you feel we waited too long for the blood product and they've decompensated to a point where it's hard to resuscitate them. So, kind of what's your threshold? And there could be no specific answer, just kind of what's your thought process? When they're going to die, you give it. When they're not going to die, you wait.
Yeah. Um, I hate to be so non-specific about it, but I don't really have any specific concrete. I mean, a hemoglobin of 3 would alarm me, but if that patient is having episodic melena and is physiologically otherwise looking okay, just a little pale, I mean, yeah, I'd wait until we get cross blood on that person. But I also am in a system where I have the luxury of being able to change that plan on a dime and switch to uncrossed because I've got that blood fridge 7 feet away from me. Um, so I think it kind of depends on the exact patient you're looking at in the clinical context, but also the resources you have available. Like once you start down that, I'm going to, send my type in cross and wait for my 4 units. If that's going to preclude you from switching your plan, because of your local resources, then you may want to start a little bit earlier than that.
Yeah, I agree. I think if someone's coming in with life threatening hemorrhage, they're dying in front of your eyes, and it's because they're in hypovolemic shock due to blood loss, they get O negative or whole blood. For so many years, we talked about the use of low titer O neg, leukoreduced whole blood. And the fact of the matter is, we know that the RH sort of status probably doesn't matter that much. So, in many centers, we're starting to give Rh positive O whole blood, which may or may not be leukoreduced, and we're not seeing transfusion reactions. In fact, we're getting blood from one person that's whole versus FFP, RBCs, platelets, 3 donors. And so the risk of having a transfusion reaction is probably higher with component therapy than whole blood. And the fact of the matter is, depending on your local blood banking practices and population, you're going to run out of low titer O neg quickly. So many centers are transitioning to O positive, and that's what we used at Harbor, whereas LAC USC used only O neg and leukoreduced, and we didn't have leukoreduced, and there's really no difference in complications.
So, Haney, let me jump in before you say something. One statement I want to make is, and I've said this before, and people look at me like I'm crazy. The person with the GI bleed and hemoglobin 3 but normal vital signs, um, I'm much more comfortable than the one with a hemoglobin of 14 but some shock, and that seems so counterintuitive, right? That like, and I'm surprised we haven't said this yet. Like, who cares what the hemoglobin is, right? If it's hemorrhagic shock,
Yeah.
it's hemorrhagic shock. All right, sorry, Haney, your
Yeah,
turn.
no, that's a good point, right? Like, again, most of these GI bleeds take place over time. So the body will equilibrate, there's going to be shifts in compartments, there's going to be hemodilution. Whereas someone gets stabbed or shot and get, pushed into a dumpster, if you just take their CBC right there, well, they haven't had a chance to equilibrate. So never be reassured when the hemoglobin's 14. Oftentimes it'll be 17 or 170. That means absolutely nothing. So examine your patient, never look at data points in isolation, and recognize that with acute blood loss, you're losing plasma, you're losing RBCs, components. So yeah, the hematocrit's not helpful.
No. It's a data point of luxury. It's one of those things that you look at when paradoxically you look at it when you have time and in stable patients and then can use it as part of your overall big picture. But again, in the super sick people, um, we typically have less data points to go from when we're making our initial assessment. You can kind of eyeball hemorrhagic shock patients from the door and be like, they're in trouble. That's so very unscientific, but I mean, there's just truly a gestalt to it.
And that gestalt is built up after seeing, thousands and thousands of patients rolling in. So there is something to be said about that. So that gestalt is appreciated, and that's why we have you here today. All right. I'm going to ask the question that Adam didn't want me to ask, but I'm going to ask it. I'm going to ask the question that I'm sure you hate getting asked every single time you give a talk on trauma. I'm going to ask that question. I'm going to be that guy. Ready?
Trauma surgeon.
What, trauma surgeon?
Are you going to say ER versus trauma surgeon?
No. We already did a debate on that. We already did a debate last year on that. We know how that went. Hashtag resusx. The question I'm going to ask you is permissive hypotension, right? In 2022, is that a reasonable structure to your approach to your patients? Is that something we should be doing? If it is, then what is the blood pressure that you look for? If it's not, then what are the things that you look for when you're resuscitating patients? Salina, what do you say? You can't plead the fifth either.
Conceptually, yeah, I think permissive hypotension is typically something that is reasonable and probably positive, especially when you're not at a place that has such robust blood banks. If you're not somewhere where they can give 47 units in an hour, just because you ask for them, then you may end up doing permissive hypotension because you have to. So think about your resources, but otherwise, yeah, typically until hemorrhage control is obtained, I don't want to cause further downstream bleeding and systemic effects of the hemorrhage. So if we can keep the systolic, I mean, and depending what you read, who you talk to, it's going to be different. And in me, it's also different, I think, from patient to patient. But I typically say like 100-ish, at least until I've got source control.
What do you
We're
think,
also
Dennis?
assuming that at this point in time that we have reliable blood pressure monitoring, because sometimes we're
fair.
doing this so quickly and so fast, we don't have the art line, or we don't really have it. We're going off of, some cuff trying to hear whatever sounds we can get in a very loud bay, but the person's extremely pale, like, and bleeding on the floor. Like, I'm going to keep going, maybe without necessarily having a number.
That makes sense.
Yeah, I
Thanks.
agree. I think, and that's why I think for like TCC, as well as civilian guidelines, we don't use quote unquote vital signs. So oftentimes when you're making a decision to initiate or not, you don't have a heart rate, you don't have a blood pressure. So you should be feel your patient. Are they cool, clammy, as was just mentioned? Can you palpate a pulse? If you can't palpate a pulse, that's a problem. That patient needs to be up in the operating room. You probably want to start your resuscitation right there and then. And it's also going to depend on your patient population. So if someone's stabbed, shot from the chin to the knees, as long as I feel a pulse and they've got some level of mentation, I'm not going to do much. I'll certainly order and I'll bring the whole blood with us up to the operating room and start giving it once we've got control. And it's going to differ for blunt polytrauma patients. So if someone's got a TBI and their GCS is low, the last thing I want to do is make them hypoxic or hypotensive, because that's what's going to kill that patient, whether that happens in the pre-hospital setting, in the ER or ICU. So some of it depends on your patient population. But I will say the Resuscitations Outcomes Consortium, ROC, and Dr. Schreiber published a great study looking at giving just small aqualots of 250 cc's of crystalloids, targeting a systolic of 110 versus tolerating a systolic of 70. And survival was better in the group where you kept their blood pressure at 70. So if you are going to give volume, I think the other thing to think about is to be moderate in terms of the volume giving, whether that's crystalloid or blood products. Maybe you give a unit of blood and then kind of reassess and reevaluate. And if you don't have blood, you should definitely be doing that. Long gone are the days of 2 liters wide open. So start with small aqualots, 250, and see where they're at. And then I do wonder, in those blunt polytrauma patients, I've moved towards giving aqualots of hypertonic saline, a little bit more oncotic pressure, small volume, maybe has some effect on the endothelium, although we know very well based on the previous ROC studies that whether it's TBI, penetrating or blunt polytrauma probably doesn't result in improved mortality.
That's great. So if I'm hearing you, it's assess the patient before you look at a number, get the amount of blood that they need, and you don't have to, once you decide to transfuse, you don't have to, unleash the dam. Like, they don't have to get everything all the time. You can be very deliberate. Maybe you give, if we're talking about 1-to-1-to-1 transfusion, well, maybe you start off with 2 units, assess. You're going to give more blood, then you'll give whatever's next in your algorithm. But it doesn't have to be once you decide to transfuse, just go ahead and transfuse. I think that's a very reasonable, pragmatic approach. And certainly people will have different ways of looking at it. But to date, that I've heard, that what both of you are describing is a very, very reasonable approach that I like, and I certainly will be incorporating into my practice.
Yeah, and sometimes you don't have that opportunity. When they're dying in front of you, sometimes all you're doing is pouring in the blood and blood products and you're not counting. But oftentimes there's a little window of opportunity to reassess and reevaluate, which is one of those core concepts in terms of ATLS.
Take your own pulse, right? And then take the patient's.
Yeah, with ours, I mean, our coolers automatically keep coming, and we have to actually stop the MTP in order for them to stop coming. But our staff has been fantastic about every time a new one's coming up, they just a real quick, hey, you want another one? And the answers, I mean, generally they have enough experience, they already know what we're going to say. But it forces us to just real quick in a split second just sort of reevaluate the entire situation and be like, yeah, I want that. Sometimes the answer is extremely easy, like, yes, I want that. Again, the staff's anticipating that need. And then sometimes it's enough time to just give you pause and go, wait a minute, actually, I think we're doing okay. Let's slow down.
Besides blood in the fridge, what other condiments do you keep in the actual refrigerator?
This is going to be a new thing.
Curveball.
I see.
Curveball.
So,
Sorry.
I enjoy listening to you guys, and I enjoyed your description, Dennis. And it's like, oh yeah, that's what I'll do. But I'd like to acknowledge that it's a little bit more challenging, right? I mean, the patient that I'm imagining, and maybe it's a different patient. I'm medicine trained, so actually I've never really spent that much time in a trauma bay at all. The patient I'm imagining is, they're pouring out blood where whatever the source is. We've been saying GI, so we'll stick with GI. And you give them blood, you give them blood, you give them blood. Their blood pressure kind of responds. They're on some degree of vasopressors because, like, all of our patients are, right? And you have to tell the nurse some sort of target. And as soon as that resuscitation stops, their blood pressure plummets. The vasopressors shoot up, and it's this like constant balance that almost seems impossible. And I really appreciate what you're saying about over-resuscitation, because I've seen these patients. We've gotten them to the OR. We get them with the endoscopist, and then the pulmonary edema comes, right? And then you can't oxygenate, and then it's just over. So, like, I think all of us have been there where we over-resuscitate these patients, and that is a horrible feeling, right? And I'm assuming, and I see Randy kind of has a question like that. He kind of stole mine, but I'm assuming, does that same concept, over-resuscitation, pulmonary edema, do you see that in the trauma in the OR? Is this a phenomenon unique to us, or what's your experience?
Yeah,
Same thing.
We used to see it all the time. Today, with the 1-to-1-to-1, we see it much less commonly. But yeah, absolutely, we'll run into problems with patients where they've got a clamshell, their abdomen's open, they've got tourniquets on their extremities, they're into their 100th unit, and they're on max pressors. Their heart's the size of a football, and all you see is the anesthetist bagging the patient, continuously suctioning. There's frothy pulmonary edema, and if they're not on ECMO by that point, they're not going to survive. So we do see ARDS. We definitely see it, but way less than when I was a resident in training. I think we've just learned so much in the last 12 years. And again, most of that comes from our military experience in Iraq and Afghanistan. When I say our, not me, I'm a civilian trauma surgeon, but we've learned so much from our military counterparts. And so we see a lot less.
Okay.
The paring back the crystalloid is probably the single best thing that's happened for trauma care in the past 20 years, at least in my personal observation and experience.
Yeah, it's amazing that our biggest and best advances, whether it's trauma or ICU critical care is avoiding iatrogenicity. Don't give your patient huge tidal volumes. Don't give your patient huge volumes of crystalloid.
And maybe
Done.
not so much blood as we're talking about it, right? Just give them what they need.
Oh yeah,
Yeah,
we
we
see overshooting all the time, and I'm sure you've seen this. Patient comes back from the OR after some major abdominal thoracic surgery, and their hemoglobin's 20. You're thinking, oh my gosh, like what is that going to do for circulation and flow?
Yeah.
yeah.
For
It's amazing to me, the recurring theme of less is more, right? Like we've seen it, we've talked about it on this show so many times. I think feeding is the only thing I found that more is that we've gone in the opposite
More is
direction.
more.
The last more is more, right? All right, so Haney, should we switch gears, or one thing we haven't talked about, and I think it's at least, and sorry, Haney, I know you want to switch, but one thing we haven't talked about is uh, uh, access preference. So we should, in any
Yeah.
resuscitation, we should talk a little bit about that. So what's your access preference? And tell me about the rapid transfuser. And because I know I find myself calling for it very frequently, and that seems to frequently be forgotten. So what's your approach to those two concepts?
You want to start, Salina? Or?
No, go ahead.
Sure. So in terms of access, ideally bilateral upper peripheral IVs. And so anyone who's shot, stabbed, especially to the torso, you're not looking to put in a fem line. I see fem cortices and triple lumens going all the time, but I would take two peripheral anticubital 18 gauges over any central access any day. Remember, most of these patients are hypovolemic. Depending on the setup in your trauma bay, you may not be able to put them into a Trendelenburg position. So it always irks me when I see non-experienced providers trying to stick a subclavian into a hypovolemic supine patient who's in extremis. I'm certainly comfortable doing that, but I think the vast majority of people are not. And so, yeah, two peripheral IVs. Avoid the IOs whenever possible. But if it's the only thing you have and you're really focusing on chemical metabolic resuscitation, trying to achieve ROS, that might be a way to go. But hopefully that trauma patient will have their chest open. Then you have other alternatives in terms of getting access to the vascular system.
Salina, you
Yeah,
feel the same?
totally. I mean, if you have the and it's weird to think that a peripheral IV is truly the luxury here, but if you have the luxury of having two large bore upper extremity peripheral IVs, like that really is the way to go. When that is not an option, as long as I'm not worried about, which I know is a stupid thing to say, but if I'm not particularly worried about massive intra-abdominal injury disruption to the abdominal venous system, just a real quick crash fem line is also another wonderful way to get access. You just got to be careful you're pouring your blood into their vascular system instead of into their abdomen or retroperitoneum.
Yeah, and in this day and age too, we didn't really touch upon Reboa, which is kind of in and out of favor. But getting early fem arterial access, I think, is very important. Even before your patient's found to be hypotensive or crashing, just having that and having the ability to have intraarterial monitoring is great. And if need be, and let's say this patient has a pelvic smash and you're worried about zone 3 bleeding, then you can swap out that fem A line for your Reboa sheath.
Well, great. We won't even go into that's a whole other episode in itself is Reboa, and I, I love talking about it, but it's a talk for another day. All right, are you both game for something we call rapid fire here? We're essentially going to just throw scenarios at you, and ask you what would be your transfusion strategy for this particular case. Now, remember this. I want you to put on your intensivist hat, not your surgeon hat. You can't take these people necessarily to the OR. You'd have to call a surgeon in this case. I know that's a stretch for you both, but Adam and I are both intensivists, and we are not surgeons. So we're going to give you scenarios and tell us what you would do in terms of your strategies.
Although, although Henny, I should say, if the surgical approach is preferred, then I am definitely interested in that, because I think all of these scenarios we'll say call the surgeon, and I laugh sometimes like, yeah, I'll be right there. For sometimes like they're already there, and I be honest, I'm not very smart, so sometimes I can't figure out which one it's going to be. So So yeah,
But it's fine if
I
you
hope
say you
that's,
pick up the phone. It's fine if you say I'm going to
yeah,
pick up the phone and call the surgeon, but in the meantime, you're going to have to do something.
that's right.
All right?
All
All
right.
right, here we go. So, lower GI bleed. Let's say you have somebody who has a diverticular bleed. They're just pouring out blood. You know they have a diverticular bleed, but now it's gone awry. What's your transfusion strategy? What are you going to be doing? And this is just rapid fire. Just shoot from the hip, and we'll go back and forth. We'll start off with Salina.
So like it's diverticular and I know where in the colon it is.
Yeah.
I mean, at that point in time, I'm just gonna try and achieve 1-to-1. I mean, do I know anything? Is this person on warfarin? Like, do I have any, is there any other information that I need to know here that I'm
No,
like,
they're
give
not
me?
coagulopathic per se. They just basically just opened up that clot, burst open, and they're bleeding. Nothing to reverse.
All right. I mean, if they're hosing from this, then they need to go to the operating room. And I mean, lovely that I already have localization, so I would just do a segmental colectomy and it would be over with. And my transfusion strategy would be balanced transfusion, probably something like 1-to-1-to-1 as I am getting source control.
Love it.
So how, before Dennis, you jump in there, how do you determine CTA, IR, embolization, OR? Like, what's going through your mind in that case? Because we usually are taught angio them, embolize them, not go to the OR, right?
We're not taught. We're not taught. When we call, that's what they tell us.
Right.
That's the. I'm not mentioning names. I'm just saying there have been times where we've called and that happens.
Yeah, so I
Dying
think this
patients
is
should not be in
something that,
CTA.
yeah, dying patients belong in the OR, definitely not IR. And this is probably just like the Reboa thing. Massive lower GI bleed is something that every general surgeon gets asked about, pimped about. This is on our board certifying exams. In this day and age, if you're concerned about lower GI bleed, I think most patients will undergo a CTA. And here it sounds like we already have the localization study done, and now they're in hemorrhagic shock. They go to the OR, they get a colectomy. If you don't have a CTA, you suspect that they have a lower GI bleed. Well, you got to figure out where it's coming from. It could be a massive upper, it could be a massive lower, it could be an occult from, we just had a recent GIST, small bowel jejunal tumor that was bleeding very briskly. But I think the way that the case is set up, 1-to-1-to-1 if possible, segmental colectomy in the OR, and that's the best place to be for your ongoing resuscitation. Because you'll have anesthesia there, you'll have OR staff, you'll have the surgeons versus just you as the lone intensivist with your ICU nurses.
Awesome.
Great.
All right, Adam, what's the next scenario?
Yeah, I have one. This is a case of mine actually. Let me rephrase. This was a case I heard about. Bedside trach gone wrong, with a acute shock and new free flowing fluid on POCUS above the diaphragm. So basically, acute hemothorax. What's the approach? I mean, we've debated chest tube size. Like, what do you guys advocate for? Percutaneous, surgical, straight to the OR? What's the thought process? Just resuscitate and wait?
So trach gone wrong, vascular injury, typically we're thinking something either thyroid. Sometimes people can go very lateral and get into the sheath. So now we're talking about typically at that level, common carotid or internal jugular injury. You can also nick the AJs or EJs. Now, if this patient has bleeding into their thorax, well, someone's doing something really wrong and probably shouldn't be doing that. So we're talking something below the level or at the level of the brachiocephalic vein, artery, or even subclavian vessels. And so if they've got a hemothorax, just like you alluded to, for sure that needs to be drained. It's dealer's choice. If you're comfortable putting in pigtails and you've got at least a 14 French pigtail and you're comfortable doing that and you have experience, that's just as effective as a large bore chest tube, meaning 24, 28 French. And then what you need to do next is based on the volume that's coming out of that chest tube. If they've got a massive hemothorax, depending on what side it's on, that patient may need a thoracotomy. If they're not frankly exsanguinating or dying, after you've made sure that their airway is secure, they're lined up, you've started resuscitation, you might have some time to at least get a CTA and identify where that injury is. Because if it is to something like the subclavian or brachiocephalic artery, for example, that would be amenable to stenting. If it's a major injury that happened to like the brachiocephalic vein and they're exsanguinating, that patient gets a median sternotomy. So it's all about the anatomy of the injury, and I think any well-trained trauma surgeon should know what to do. Yeah, but first things here, make sure that airway's secure. They're not soiling it with blood, and then figure out how much blood is coming out of that chest tube. I don't know, Salina, what do you think?
No, I think pretty much the same thing. I put a chest tube in, not just to decompress the pleural space, but also as a kind of a rudimentary dipstick of how much they're still bleeding. It's just another data point. Anatomy here is going to be everything. Trying to gauge what your best surgical approach is going to be, thoracotomy versus sternotomy if they need it. Generally important to kind of have at least some clue of what you're going after. Though that's not always the luxury. And honestly, so many of these vascular injuries now can be stented. And I mean, if I were a patient, I would much rather have a subclavian stent than a sternotomy. So again, if you, I would resuscitate, and I would do my best to try and get the patient in a position where I could have some sort of localizing imaging study.
Great.
So
Last
what
question.
happened? What happened?
So-
Where was the bleeding?
As I said, it wasn't my patient. I just heard about it. Uh, and was not a Cooper, I should say. Haney, before you move on, I just want to make the comment. We had 2 surgeons endorse percutaneous chest tubes.
I know. I think
actually, Salina didn't endorse it. I'll say 1 surgeon endorsed.
You know what?
percutaneous.
I'll take that back. I think I like Salina's approach. I think putting in just a large bore standard chest tube in the setting is important. I don't remember the term you used, but you said it and it resonated with me. It's sort of your gauge to see, oh, this is a massive hemothorax. That might not be the time to get too skillful and wait for blood to trickle out.
in terms of a speed maneuver, right? I mean, saying that the pigtail will take, I mean, it doesn't take that much longer, but it does take a little bit more time than doing just,
Yeah.
opening up the pleural space and letting it drain out.
And it might take more time to evacuate that blood. I think as soon as typically once you if you're putting a chest tube in, you make your cut, you get your finger in. If there's a massive hemo, you're going to know it. That blood gushes out onto the bed. You put your chest tube in. So as I'm thinking about it, I would change my approach, because if you're just doing a needle, wire, pigtail, well, you might not get a sense. Of course, you're going to get a chest x-ray, and that should also help guide, how much blood is in there. But yeah, I think open chest tube thoracostomy is the right way to go in this setting.
Then I'm going to forego my last question, because I love this topic. And Dennis spoke on it at ResusX last year. My question to you then is, are we getting to the point, forget about this case, but are we getting to the point now in trauma care where we're starting to transition now to 14 French catheters in the trauma bay? And if that's so, which patients would you not, we certainly talked about this case, but which other patients would you not go to a 14 French pigtail catheter, and which would you still do open? Dennis,
Yeah, for me, there's very few people that I wouldn't use a pigtail 14 French. I think the data's there. It's prospective. It's randomized and controlled. And we're not just talking about pneumothorax or hemopneumothorax. We're talking about unstable hemopneumothorax. And so the outcomes overall are the same. You're not going to have an increased risk for retained hemothorax, need for a VATS, but patients have better outcomes in terms of pain because pigtails are much more better tolerated. Probably the one scenario where I wouldn't choose a pigtail over a chest tube, and this is so rare, but if I got a chest x-ray on a blunt polytrauma patient, or even a penetrating wound to the chest, and they've got massive subcutaneous emphysema and a fallen lung, and I'm thinking they've got a major tracheobronchial disruption, that person's getting a chest tube, they're getting fiber optic intubation, and I think that might be the one rare case where I would go with a 28 French chest tube over a 14.
What do you think,
The
Selena?
other the other time that I would is if I was worried about diaphragmatic rupture, particularly on the left. The last thing I want is somebody sticking a needle in there. I actually would, if I have to simultaneously decompress the chest and I'm worried about diaphragmatic rupture, I would want somebody to actually be able to put a finger in there, so they can kind of have an idea of what they are doing and where they are, in relationship to whatever this new anatomy might be, rather than assuming the anatomy is normal and sticking a needle into something that doesn't want to be needled.
100. Great point.
Fantastic. Well, Adam, do you have any more burning questions? We've taken up these folks' time by asking them their favorite condiment and all sorts of blood transfusion strategies.
What happened to the patient? What was injured?
I ignored it because I don't actually remember. It's terrible.
It was a
terrible.
hypothetical
It
patient.
was a hypothetical patient.
Hypothetical.
That,
Gotcha.
I know they went to the OR, and I know it didn't go well. That's what I remember.
Gotcha.
Hypothetically didn't go well.
But yeah, Haney, I have a million questions, and I'm looking here. We have like 7 scenarios, and we only got to talk about 2. But I think maybe we'll save it for another time. Actually, let me ask one question. Can I ask one more?
Nothing about ketchup.
Gotcha. Why? It seems that we're more excited about acute blood above the diaphragm than acute blood below the diaphragm. I mean, why do we not as aggressively drain a new acute hemoperitoneum? Is that tolerated better? Is it just, are we worried about compressive of the lung and gas exchange? Or is really acute hemoperitoneum to the OR and it's going to get drained there anyway? So what's the point? Or is this just a dumb question, which it very may well be?
No, I mean, I think I know what you're asking. I would say that in the setting of trauma, 85 to 90% of all thoracic trauma is treated with a chest tube. So whether that's a pneumo, massive, hemo, open pneumo, provided that you occlude the hole. And that's all you usually need. There's only about 10 to 15% of patients in the setting of acute trauma who will need an operative intervention in their chest. Bleeding into the abdomen, that's usually surgical. I mean, we'll have patients who have solid organ injuries and they're amenable to angioembolization, as we've learned from the pediatric literature, and now we have a vast adult experience. But I would say most patients with intra-abdominal hemorrhage usually, especially if they're unstable, need some sort of intervention. And that's one of the basic tenets of trauma surgery. Hypotension, peritonitis, abdominal trauma, golden ticket, OR.
Yeah, but if you have that person who is stable, who has a grade 3 spleen, who has some hemoperitoneum, you saw a little bit on FAST, but they're totally stable, or you picked up a little bit on CAT scan, whatever. Yeah, that tends to be relatively well tolerated. People will have discomfort, people will have abdominal distension, but it's not, I mean, having a hemothorax you don't drain and ending up with a trapped lung is potentially of greater consequence than leaving 300 cc's of blood in the abdomen to be reabsorbed. So I think that that's probably why. The other thing is the abdomen is an elastic cavity that you have a lot more give, and can tolerate more distension, whereas the chest wall is a relatively rigid and fixed space. The mediastinum can shift a little bit, but you don't want it to. You don't want to change the interplay of the thoracic dynamics any more than you have to.
Yeah,
Makes
completely.
sense.
And then on top of that, there are cases where, Salina, you've probably done this, where patients do have intraperitoneal blood. There's no acute indication to operate. Maybe they had a liver smash or a spleen smash or the mesentery was bleeding. Sometimes these patients are just miserable. They've got abdominal pain, they're burping, they're distended, they've got an ileus. Those are patients that will sometimes put a camera, a couple of the chopsticks, suck out all the blood, and then they feel great. So occasionally we will drain that blood in the abdominal cavity. And then definitely if they have abdominal compartment syndrome as a result of blood loss, they get a decompressive laparotomy.
That almost begs a really one of the quintessential questions in surgery is, does hemoperitoneum cause peritonitis? And that's a debate that always gets quite heated.
I'm on the
But yeah,
pro
I mean, some of
side.
these
Yes,
folks,
it does.
I'm actually on the pro side too. I think that blood, not necessarily in the acute setting, but definitely after it's been sitting there a couple of days, it's going to irritate your peritoneal lining. And some of these folks get a pseudoperitonitis. And it's happened more than once that you end up, like you said, somebody's really tender. You end up opening them because you're not entirely sure, is that blood or is that possibly succus entericus? And I'm sitting on a truly peritoneal patient, and they're so miserable. Yeah, it's hard. Sometimes it's hard to tell clinically.
Is there ever a role, like, how about the anasarchic patient, the dialysis patient or the cardiomyopathy patient? Is there ever a role for percutaneous drainage just to see what it is? I mean, is there, or is that that would never be a thing? Do either put a drain in or just do a paracentesis to see what the fluid is?
I mean, unless there's a good indication to do so. So if you think they've got SBP, or you think that it's contributing to intra-abdominal hypertension or abdominal compartment syndrome. So I think very rarely for diagnostic purposes would I do that. And then there's going to be some limited opportunities or times I would do it for a therapeutic reason like ACS.
Okay, that makes sense. Okay.
I mean, when you think about it, they did DPLs and DPAs for a very, very long time. And positive gram stain was one of the things that would make your DPL positive. So, I mean, is this something that they not exactly what you're saying, but is this something that has been done in the past? Yeah, but there's a reason why it's fallen out of favor, fallen out of routine practice.
Yeah. No, that makes sense. All right, sorry, Haney. I'm done now.
No. This is all
I could
awesome.
keep going.
That's what this show is. We just go off on tangents, and then we get to pick these geniuses' brains. So I'm so grateful that we went this far. And I do want to let you go, though, because we're run past the hour. But let me just start off by saying, Salina Dennis, thank you for being on the show tonight. I learned a whole ton of stuff, and it was great to just see the inner workings of what you see and what you think about when you approach the patient who's in shock for you, whether they're trauma patients or the medical patients. So it was great having trauma surgeons and intensivists on the program tonight.
It's always fun to talk with you,
Adam Haney.
Thank you.
Thank you, guys.
Yeah, thanks, Salina. Good seeing you all.
Thanks. Hopefully we'll get you on in an episode in the future. Be safe, everyone. Cool.
Take care.
Night. Adam, another great episode in the, what do you say, in the can, in the bin? What's like the term? What do they say in the business? In the file folder?
This is the second question that you asked me, and I have no idea how to respond.
I don't know if I just made that question up, but yes, sir.
So this is what I was thinking. I always think it's interesting when you have a kid and it's like they're 1 month, 2 month, 3 month, and then you switch to like, oh, my daughter's 2.5, where you stop counting the months. Mm-hmm. I think we crossed that barrier here. Notice we didn't say what number. We didn't say what episode number. This was the first one we didn't do it. So I think that means we're now toddlers.
I think we're crawling. We're crawling now, and we're done pooping our pants. Well, we're close to pooping our pants. The condiment question was kind of a poopy pants question. I'm just messing with you. No. I'm just.
And I thought it was exciting, and
it was a good idea. It was executed. I think it was just such a curveball. You got it on the inside corner, and you caught the batter. That's what you did.
Oh, well.
No, it was good. It was good. Hey, listen, what are we doing next week? We're doing something special next week.
Yes. Are we calling it Shorty? Are we calling it
Shorty?
Reverse?
No,
Reverse
Shorty.
Lounge, just Shorty.
Nope. Shorty is a great idea that Adam came up with, and we're doing it. So if it fails, it was your idea.
Yeah, I'm sure. And if it was successful, it's entirely because of you.
Yes.
What I would like to do is have guests come on, ideally with the camera, even if I don't know if we can pull that off from a tech standpoint.
We have the technology.
Have them come on and ask us questions, and just kind of put us on the spot, and you and I spitball, and we just do that. And we call it Shorty because I anticipate it's going to be about 20 or 30 minutes as opposed to the full hour.
That's what you think. We have so many fans, it might go on to the wee hours of the morning. But for all of you out there, here's what we're planning to do. Please submit your questions. I'm going to be putting posts out on social media. Put in your questions and put in if you want to be live. If you want to be live, we will contact you. We'll figure out a way to DM you, contact you, give you the link to get on the show. You can come ask your question live. We have to do it this way because these days there are Zoom bombers and all sorts of nonsense that happens. So put your question in, and if you want to be on, we'll bring you on the program. If you don't want to be on the program, that's great too. We'll just ask we'll say who you are, you ask the question, and we'll answer it for you live. We want to start incorporating you, the audience, into the show because we're so grateful for you spending time with us. So look for the posts on social media, put in your questions, say if you want to come on live with us. We'll have you on to ask your question, answer your question, and then we'll kick you off and let someone else back on the air.
And it's also shortly because it's in 1 week, not 2. It's next week that we're doing this. In fact, 6 days from now, next Tuesday. So it's coming in hot.
Yeah, and Shorty, if you like 50 Cent, you get the Shorty reference. Is that right? It's your birthday? I don't know. Okay. Listen, folks. Thank you all for being here today. Adam and I are truly grateful for our growing fan base here on the Critical Care Lounge. Don't forget to subscribe and like to the channel. And I'm going to let Adam close out the show today. Don't mess it up.
Oh, I don't know what to say. I've never done this. But thank you all for joining us. And next week, we'll see you at the Shorty.
Take care.